Our next session, we've got Professor David Sanders, who's a professor of gastroenterology and a consultant gastroenterologist at the Royal Hallamshire Hospital and the University of Sheffield. He has published over 400 peer-reviewed papers and is internationally recognised for his work in coeliac disease, peg feeding and small bowel endoscopy. He has a multitude of awards, and if I was to list them all, we wouldn't have enough time to listen to him talk, so I'll let him take it away with his talk on raised TTG, what should a dietitian do?
Yay, thank you, and thank you for inviting me. So I want to talk about raised TTG in the context of adherence and adult coeliac disease. And the thing I want to say to you is, I want to put a suggestion to you, which is that everything that we do is wrong. There is my suggestion, and let's just see what I mean by that. So, in answer to your question, when we're looking at adherence, when we're thinking about how we assess adherence, there are a variety of options, aren't there? We can ask the patient. We can have a professional, a dietitian, expert in their field, making that assessment. Or we can use these validated questionnaires or scores. And they all sound fantastic. But of course, broadly, they're compared against serology. And we like serology because it's a number. It gives us a quantitative estimation, a figure that we can use. But there is a problem with those first three methods. And do you know what that problem is? I'll tell you what it is. It's humans. Because humans love to lie. That's what we do. It's one of our favorite things. Are you adhering, Dave, to your gluten-free diet? Yeah, of course I am, Julie. Absolutely, I am. Rachel, I'm very good with gluten-free diet. Never break it, never do anything. Rice and potatoes, me, every single time, every day, gluten-free all the way. And it's absolutely not true. So you'd like to think, you'd hope to think that actually serology will counter that and will give you an objective measure if the patient or the person thinks, oh, I quite like seeing my dietitian. I don't want to tell them what I'm really up to. It'll probably upset them. But here's the problem in answer to that question. If your TTG is positive, then it correlates to about an 80% chance of having villus atrophy. And villus atrophy, as you all know and will remember, is the ongoing inflammation in coeliac disease. So let's just stop and think about that. What does that mean? That means if you're sitting in clinic and you have a patient who has got a raised TTG and you say to them, well, you know, Dave, maybe you're not really adhering to a gluten-free diet. On 2 of those 10 occasions, that person may have normal villi. So what does that do to them in terms of how they feel at the end of their appointment, having gone through this process with you? So we have a problem. Let's turn that on its head. Let's look at it the other way. What happens if we're in clinic and we have a negative TTG? So we see our patient, we think they're doing really well, but their TTG is negative. So that sounds really good, doesn't it? The stats add up. What do you think the likelihood is that they have villus atrophy? Hands up those for 5%. Hands up those for 10%. Hands up those 20, 50. Hands up those for 100. Hands up those who will never put their hand up no matter what question I ask you this afternoon. And the answer is a shocker. So this, for me, rocks my world. I cannot believe it, but that probably tells you how small my world really is. The fact that actually, if you have a negative TTG, you still have a 50% chance of having villus atrophy on a biopsy. That is incredible. So that means half the patients that we see, where we say, oh, you're doing fine, your TTG is normal, they actually have ongoing villus atrophy. So we have a really, really big problem. I say again, everything we are doing is wrong, maybe. So what is the reasoning and how do we handle this? The thing is that the relationship between the TTG and villus atrophy is imperfect. There is no doubt that if your TTG falls, that's good news. It is a good marker of adherence on some level, but it doesn't have a perfect correlation with the persistence or the presence of villus atrophy. Why does that matter? Well, villus atrophy, ongoing inflammation, is the only thing that correlates to complications with celiac disease. Nothing else. Not symptoms, not what we think, not blood tests, just the presence of villus atrophy. And that makes biological sense because that is ongoing inflammation. And it is that ongoing inflammation that increases your risk of hematinic deficiencies, increases your risk of gastrointestinal malignancies, reduced bone mineral density, and so on. So I want to change your mind, I hope, and give you a different construct, which is that when patients come to you and you're having this discussion, if you really want to know about what's going on, if you really want to see whether they have gone into remission and no longer have villus atrophy, you have to do a biopsy. That's the only way. And here in this jigsaw, I've tried to break things up to make you have a think about how I think of it in my head. The top two pieces both have normal biopsies. So if you've got a normal biopsy, fantastic, no risk. No symptoms, normal biopsy, brilliant, no problem. Got symptoms, normal biopsy? Well, one of two options. Option one, you've got something else going on, either associated or unrelated to celiac disease. Option two, and quite common, functional gut symptoms superimposed on your celiac disease. Seen more frequently in people with celiac disease, not unsurprisingly, because it is a GI disorder. And we and a number of other centres have shown the value of trying some form of FODMAP diet superimposed on the gluten-free diet. What about the bottom two segments of this jigsaw? Here's the problem. If you have villus atrophy and you have symptoms, then you can work with these people and you can talk to them and see how to try and improve things and make things better and perhaps get them to a place where they are feeling more confident. But if they don't have symptoms, that's a tricky one, isn't it? Because they're going to say to you, hey, why do I need to be more carefully adherent? What is it you want from me? You've already messed my life up with my 3 meals a day and all the choices that I have to make. And all we can really do for that group is to talk to them about the risk of long-term complications. And I view this as informed decision-making. We're explaining to them what we think may occur over the passage of time. And even then, I would say to you, the risks are modest. So we just need to let our patients understand what the decisions are in front of them. And I think the big message here is, let's face it, and I think we all know this is true, GI dietitians know far more about celiac disease than gastroenterologists. It is the cornerstone of management is GI dietetics. And so I would have no hesitation in your shoes in saying you need to tell your gastroenterologist, or we need to go back to your gastroenterologist, and we need to consider a biopsy if we actually want to see what's happening. But there are caveats to that. There are nuances to this. Here is some data looking at 3 or 4 different studies where you're looking at timelines. So you can see along the longitudinal axis the number of months passing, and you can see on the vertical axis the percentage of patients that go in remission with the passage of time. And the message is really clear. With every year, these patients are more likely to go into remission. Now, it might be that they are actually adhering more carefully, they're learning more and things get better, but there may also be a process of natural healing. And for each individual patient, that may take time. So if we say, oh, you're 1 year in on your gluten-free diet, you feel great, and you then say, well, we should do a biopsy, then the likelihood is for 50% of them, they're going to have villus atrophy, even if they have no hematinic deficiencies, even if they feel well, even if their symptoms have improved. So we're kind of stuck. We have to almost have an arbitrary suggestion of maybe 2 years, maybe not at all, maybe only if they have symptoms. So it's having that dialogue with your patients that is really crucial. Let's confuse the issue further. Here's a fantastic study by our friend and colleague from Italy, Luca Elli, looking at his patient cohort, almost 1,400 patients, and 8% of them reported ongoing gluten ingestion. And you can see the kind of quantities we're talking about there. A long period of follow-up, on average 8 years plus. And for those patients who said they were eating gluten, 57% of them still had a normal biopsy in their remission biopsy. So some form of immune tolerance is occurring. When we say to our patients, 20 parts per million, this is what you've got to do. If you don't do it, you're a bad person for the rest of your life, then that's great. We do have to swear them in at the beginning to really see the benefit and the effects and how it will work and to avoid progression to complications. But with the passage of time, each individual may vary. There is probably a Gaussian distribution into how they actually immunologically respond. So if you haven't heard of this test, this is an important and valuable test which I think will be commercially available soon, but we've been using it in studies here in Sheffield. Gluten immunogenic peptides are excreted in the stool and in the urine for anyone if they eat gluten. And here we've been using a point-of-care test for this. Urine is obviously much easier to collect. So we've looked at 40 patients almost with refractory celiac disease type 1. So remember, these are patients who have got villus atrophy ongoing on their biopsy, and they swear to rights that they are not being exposed to gluten. You've assessed them, and their gluten-free diet appears fantastic. If you do 3 urine samples, 2 at the weekend, 1 during the week, you're most likely to get a positive or valid finding. And that's because the greatest likelihood of deliberate or inadvertent non-adherence or exposure to gluten occurs at the weekend, eating out, socializing, etc. And you can see from this study that in this group of almost 40 patients who've said, I don't eat gluten, never ever, potatoes and rice for me, 50% of them have actually got a positive GIP. And GIP tests at a level of about 40 to 80 milligrams, depending on the kit. So it's really difficult. A gluten-free diet is really hard. We don't need a medic to say that to a group of dietitians. So what do we do? Well, this figure which we put together, when I say we, it was actually Pom. It probably took him 3 weeks, and I'm going to take the credit for it now. But you can see that it's trying to put everything in there. It's trying to make you think about the individual patient. What if they have hematinic deficiencies and they have a positive TTG? Well, then that's kind of pushing you towards not adhering, isn't it? The likelihood. So you have that discussion with them. You talk them through the different options, but always be mindful of the fact that they may be slow healers. They may be inadvertently exposed to gluten. They may actually be very sensitive immunologically, and even a gluten-free diet might be enough in terms of exposure to gluten to keep things ticking over. We don't know, but we do know that time heals. And ultimately, that group that we're all worried about, refractory celiac disease, true refractory, is very uncommon. So I would conclude by saying, as I said at the beginning, everything that we do is wrong. That's not really true. But we certainly have nuances that we can learn and a different way of tailoring our approach to these patients on a personalized level. And I think the key things here are, please understand that the relationship between adherence and mucosal remission, in other words, persisting villus atrophy, is imperfect. Don't rely on a TTG in isolation. Don't look at a TTG and say, fantastic, it's negative, so they're doing really well. Have a low threshold for recommending a biopsy and telling your patient, actually, this is what you need, and we need to tell the gastroenterologist to do this. I probably would arbitrarily set that at 2 years or 3 years if they're feeling well and if they want to know. They may not want to know. They may not want to have a horrible gastroscopy. If they have persisting symptoms, straight back to the gastroenterologist. And finally, be aware that immune tolerance occurs and that with the passage of time, for an individual, things may change. Thank you very much.
Thank you, David. That was an absolutely fascinating talk and very much food for thought. So, does anybody in the audience have any questions at all?
Dave, thank you. Brilliant. Can I ask, do you know of any data that have looked at this cohort of patients who either are positive for the transglutaminase, or they have still have some inflammation in the bowel 20 years down the line or 30 years down the line. I mean, is there anything bad about this group of patients? Are they going to be the ones who develop cancer and so forth? Has anybody done that?
Yeah, for the villus atrophy group, that's been shown. And that's the group that tend to have reduced bone mineral density, hematinic deficiencies, and so on. There's great uncertainty about dividing people with positive TTG and negative. I haven't seen any data that clearly separates them. And, you know, hopefully in that talk you saw the vagaries of that, of using TTG. But, you know, I can see what you're saying, and it would be worth looking at, because you can't help but intuitively think a positive TTG must have some relationship. And I agree with you. Of course, Chris.
So I guess, Dave, my question is, what role do you think GIPs play at the moment with the management of celiac disease, and what do you kind of foresee in the future with them?
I think it's a composite assessment, like in that jigsaw. I think, first and foremost, dietitian. Mm-hmm. Then, if you want to use scores and etc., fine, but understand their limitations. Do the blood test. These are all non-invasive things. GIPs are, I think, going to be available in places like Boots soon. So, but equally, you don't want to torture a patient with their GIP. You know, if they're doing really well and everything seems fine, I don't think we should beat them over the head for inadvertent or socializing or so on. It is a question of balancing and not making them have such an awful, it's Kevin Whelan that created that term, fantastic term, food-related quality of life. It would be terrible, and you may even have more extreme eating behavior as a result of this. So it's composite, and I think it's in your hands.